everyone. I'm John Lynn, the founder and chief editor at Healthcare IT Today. We're excited to bring you another in our series of health IT interviews. And in this one, it's actually a return visitor. We, after our last interview, we started having an after conversation. I'm like, we need this on the record. We need to share this with the Healthcare IT Today audience. And our guest today is John Kalix. He's CEO at SOC Telemed. Welcome, John.
Good to be back. Thanks, John.
Yeah. So, like I said, I'm excited to dive in there. But for those that didn't see the previous one, that don't know about you and your company, tell us a little bit about yourself and SOC Telemed.
So as you can imagine, the healthcare, when you think the word telemedicine, it's just this giant word.
Yeah.
Where SOC Telemed specifically focuses is in this unique area of acute care telemedicine. So this is not a patient to physician created connection. It's a B2B transaction between SOC and a hospital, and then a physician on one side activating a specialist on another side, or it could be a nurse, or it could be someone on the floor of the hospital. But what it's not usually timed. We know at 3 o'clock a visit needs to happen, and we're going to provide a generalist in that case. This is high intensity acute care telemedicine. Come into hospitals where either reach or access or mix is in need, and that's a space that we've been playing in now for 14 years, and obviously it's a tremendously growing space since the period of COVID.
Yeah, definitely. And, everyone should go check out our previous interview where we dive into the specialty specific telemedicine. I like to say the only telemedicine that was successful prior to COVID or nearly. There was some direct to consumer maybe, but it's probably the most successful prior to COVID, but certainly is doing well. But today we want to really dive into kind of the economics of it and kind of the aspects of it that really make sense, and why does it work and where doesn't it work? So, let's dive into that. When are some times that really a healthcare organization would consider using a specialty telehealth solution like yours, with their specialists, and when wouldn't they?
It's a great question. And I think just to step back from even just our footprint nationally, we're more than 1,000 locations. We're at more than 700 hospitals specifically. But geographically, half of our customers are in rural type locations and half are in urban type locations. And we're spread across all 48 states. So it's not a matter of the size of the hospital. Hey, we can find specialists in the big cities, but we can't find them in rural, or vice versa. The need is really diffuse, and it's really individualized by the type of specialty and honestly just the demand in certain and different communities. So many times a hospital's trying to navigate, look, we really need to take care of our patient population, our community, because we can't locally provide stroke care. And we talked a little bit last time on how to think through acute care telemedicine and stroke, right? It's time intensive. Ambulance is picking someone up at home. They think it's a stroke, they're not sure. They're driving to a hospital, and they know which hospitals are stroke certified. And so they're going to that location at that point in time. And so if the hospital closest to someone having that episode is 2 hours away, they're going to go there. And they're going to drive past a lot of hospitals that don't have a stroke certification, as an example. Mm-hmm. And so the ability to treat patients regardless of location. So you might be in a really dense city where traffic is still an issue, versus you might be in rural America where it's 2 hours to the next hospital. Every hospital is trying to think through, how do I take care of my patients in my community to avoid transfers, and to just be mindful of time is brain. In stroke, you're losing millions of neurons every single minute. And it matters, not just can you get the care, but how fast you can get the care. So it's a problem it's going to be a continuous issue in healthcare. If you look at graduation rates in the medical schools, it's not increasing, and specialists and the complexity of acute care telemedicine is only going up. So it's demanding more cardiologists, nephrologists, neurologists, psychiatrists, internal fetal medicine physicians, and specialists, as we're trying to provide great care and make sure you're either taking care of your community, or you're able to take care of your community by staying open as a hospital, by keeping that revenue in your community versus it leaving, and then hospitals run the risk of closing or having to tighten their belts.
So if you're a large hospital, the idea of timeliness of the care really matters. And is that why they work with someone like SOC Telemed, is because they don't want to staff up that number of specialists, or is that really the biggest reason? Because timeliness matters and they don't want to, or maybe they can't get that many specialists into their organization?
It is really a balancing workload element, right? And so you need supply side elasticity if you just use a general economics term, right? But if you bring that down to healthcare, in any particular day, you might have a specialist consistently seeing a patient every hour, and they're busy, they're hustling, but they're able to give good quality care to every single patient. Other days, only 2 patients walk in the door with your specialty, and therefore there's downtime. Well, that's time that you could have been seeing another patient, but they just don't happen to be inside your 4 walls. And then there are other days where you have 8 hours and there's 20 patients in need.
Sure.
So how do you staff up for that? Do you always keep now 2 specialists on site all the time? So you're solving for the peak. But if you're solving for the peak, you're typically then there's time that's not being utilized to see patients and treating those patients. And if you solve the other way, right, you have burnout. You just simply people can only work so hard and so fast in such an intense environment where specialists, physicians, nurses, I mean, the element of burnout healthcare is real. Mm-hmm. And some of that's driven just by demand load, not just sort of the emotional toll that, taking care of patients and caring for patients it has in the hospital setting. So this really is about demand flow and how do you maximize every single specialist that's out there, every single clinician that you can. And it might be weekends, it might be evenings, it might be peak time, might be 11 a.m. one day, but it's not until 8 p.m. the next. And because that uncertainty is there, because we're not talking anything about scheduled patients, you have no idea what's coming in the ED or into that OR at any point in time, a solution is needed. And that's one of the things I love about working with the SOC team is there's this real innate sense that healthcare can change, and it's happening right in front of our eyes right now. Technology can enable that. Specialists adapting to these new technologies can enable that. And hospitals looking towards the future, saying the direct-to-consumer visit we all have at home, I can bring that into my hospital, and I can actually provide great quality care with generalists and other individuals by pulling in specialists. So I don't have to prevent that kind of care coming to my patients regardless of where I am.
Yeah, I think it's interesting the comparison between what you just described and what cloud computing has been saying, right? Like, when they're doing research, you say, okay, do we need to buy a server and storage and processing for the peak? Or do I just buy in the cloud and it bursts for me, right? That's kind of what you're describing but from a human standpoint. How do I burst human capacity across many organizations? And is that what you're able to do it? Like, help people understand how SOC Telemed is able to do this, whereas a local organization is not. Is that because you're working with, you said hundreds of hospitals, and so you can leverage, your change is not as dramatic as it would be for an individual?
There's a lot in there too. So pure volume allows for your peaks and your spikes to be more level, right? The bigger the volume gets, the less of the dynamic where you need that supply side elasticity for the demand. Exactly. We actually have data analysts that sit there and just spend time trying to understand what's the difference between Mondays and Tuesdays, year over year, week over week. And the more data you get in, the more specific and actual you can be. Many, many other businesses run themselves this way, right? If you think about everything from the Ubers of the world to you think about NetJets, if you're doing shares of jets, to you said you can think through all the examples, and healthcare can be the same. That human touch is the element that I think first had individuals and hospitals think through, can this really activate and help improve healthcare? What you really see though is by touching more patients at those critical moments in these really specialized cases, it's like a sports analogy, right? More swings at bat, the better I get at my batting percentage. Having people see really complicated cases more often and bringing those specialists to those locations allows high quality care where it's going to always be an issue out there. We're trying to solve X% of that issue. Ultimately, we're going to need more specialists helping in these areas. You're going to need other, artificial intelligence and other avenues will help continue to evolve the curve. But in the end, you want specialists with seeing that patient, examining that patient, looking at their labs and their images, and providing a team approach, because it's not just the the specialists on at the other end of the telemedicine, like we're having here, there's a team around that patient, and making sure all of those signals get played out for high quality care is complex. So you have to we built Telemed IQ, which is our proprietary platform, over the last 6 years. We have nearly 1.5 million patients that have gone through that specific process. And so you do learn a lot, right? You learn every time you see an error or an issue or a near miss, you can learn from those near misses and improve the thought process. So it's not done by human element, it's done by thought progression and process that keeps getting put into coding that makes us better and better at this. And I think that's the difference, John. It's if you try to do this initially without those learnings and with all those other insights, this is high acuity care. The downside of something going wrong, if you're just trying to learn into this, is significant.
Yeah.
And I think by making sure you're very patient-centric, patient-focused, people are looking for expertise, and that's what we've been spending years learning. It takes a long time. You can't do this as a fast startup, given the complexities in this environment.
Yeah. And, that was the thing I came out of our last discussion, was just how deeply integrated you had to be successful. So I think that's a powerful message. Let's talk about the economics though of it, right? I mean, you talk about that there's not going to be enough specialists, which I think is interesting. So the question is, are you helping to make this more efficient on a per specialist basis, right? I assume so, because the specialist has a full day rather than some days a full day. In fact, some days too full of a day and some days not, right? Which I guess contributes to the burnout discussion you mentioned previously. But what are the economics from, also from the hospital's perspective? Does it cost them extra to outsource this, or, how do they think about that?
I think before telemedicine really became more common and is now being thought of in these other specialties, which it really hasn't been considered. It was thought in telestroke for years, but in a lot of the other specialties, it really hadn't caught on as deeply outside of the emergency room department. Uh-huh. I think a big part of that is trying to understand what are the financials, but also what are the old tools. When you have a toolbox, you always reach in for that same hammer that you always utilize, right?
Yeah.
And eventually say, hey, instead of the screwdriver, can you pick up a drill instead? And the first time you try the drill, you're like, wow, this is way more effective than that screwdriver I've been using for the last 30 years, right?
Yep. But never underestimate the power of how I've always done it, right?
And that's just it. So, the old way of looking at the process was, okay, we're going to think through how do we use locums to make sure we always have someone on the bench should I need to call on someone, because I have no idea if so-and-so is going to be out sick, or if they're going to be taking a vacation, or if I know the next day might be bad because we know some events happening, right? Sure. Or you had the per diem model, which is still very effective. But again, locum and per diem, if you think about anytime you need on-demand, sort of not consistent help on anything, go outside of healthcare, it usually costs you more, right?
Of course.
It just does, because access and time usually means money for just about anything that we purchase anywhere as a consumer. And that same thing happens when you're talking about any physician, any nurse, any specialist. You can go use a locum or per diem for those upside elements, but that's a much more expensive approach. So the other side of it is, okay, I don't have that. And I basically, on certain days, I won't run certain parts, or I won't offer certain specialties on Thursdays or Fridays. The hospitals may not have ORs open at other days, right? They navigate for what they have to make sure they're providing good community care, but they also know what they have and don't have from coverage to provide that care. Mm-hmm. So your options were, I either use more expensive on-demand help that has clinical expertise, and or I go ahead and try this other element where I just don't bring in revenue on those particular elements. And both of those are really expensive trains of thought. This allows for, because you're fractionalizing time, you're basically sharing resources that they're wanting to provide good clinical care. I think a lot of physicians and specialists on our teams realize they're behind the windshield. That's a whole other patient they could be helping, right? Yeah. People really do go into healthcare to do both good and well. And if you're sitting there behind a wheel, sometimes you need to tune out. It's again that burnout, that stress element, other pieces. But other times there's a true desire, like I could be using this time differently
Mhm.
than driving to the hospital down the street and providing care for the next 3 hours. If I did this all at home, I would have seen 4 more patients.
Yeah.
You follow that through and you think about the financial dynamics that you can, that time, you're not buying time in hour blocks, you're buying time in partial blocks. And therefore, it's a more effective, cost-effective scenario for hospitals. So when dollars used to matter, dimes now matter post-COVID, and people are now looking at other technology elements, it's a very compelling either cost or new revenue stream as you think through telemedicine strategies.
Well, and I think what's fascinating about what you just described is this works well in the current fee for service model where, it could be new revenue, as you said, right? That you would have missed out if you decided not to have that specialist, or, it could be preventing, a long admission that's going to cost you and have issues with hospital readmissions type stuff, right? And how long are they going to get paid, right? Whereas they would have been paid well because it was a shorter admission. But it's, then you look forward to where we're going, the value-based care. It's like in a value-based care model, you really couldn't even think like, oh, we're just not going to have that specialty for these 2 days. Like that was revenue, but in many cases, anyway, it seems like the ROI gets even better in the value-based care world that we're hopefully getting to.
Yeah, and there's a lot changing in telemedicine in general as hospitals navigate. So in acute care telemedicine, there hasn't classically been the reimbursement that there is for more direct-to-consumer telemedicine.
Yep.
So in direct-to-consumer telemedicine, it's been relationships between payers, employers, hospitals, et cetera. That hasn't been the case in acute care telemedicine. In fact, the very first time any reimbursement took place in acute care telemedicine was in neurology that started in 1999, or 2019, I'm sorry, 2019. So it's only been 2 years.
Wow.
And then the national emergency brought on some changes. And right now they're trying to understand, how do we look at acute care telemedicine? How do we look at direct-to-consumer telemedicine? And so most of this was not a reimbursed element. It really was, if I can get the time for the specialty, the other reimbursements help hospitals remain bringing the revenue they need to be helping take care of their communities. But it's just a constantly evolving element, which is why, again, helping really think through taking really highly trained individuals and making them accessible where they can be solves the patient, doesn't solve, but it largely solves for patients that have no access to this.
Yeah.
Because again, we're going to still need many more specialists and nurses and others out there, but it definitely helps solve for the element of, look, we can actually find different revenue streams from having access to these specialties.
Yeah. And as jaded as I've become from the business of medicine, which is challenging, there is still, and I think it's especially true in the emergent care area of saving lives, right? I mean, that still matters. So, to your point on the stroke that we previously talked about, that's someone's quality of life that you're going to impact in a big way. And that stuff really matters still.
It does.
So let's talk about from the doctor perspective. What's it like for them? What's the experience of a specialty doctor doing telehealth versus in person? You kind of talked about the commute, which that one hits home for me a little since I've worked at home for the last 10 years. And when I first started, actually it was 15. Anyway, I lose track. It's been a long time. But then I started, I missed that drive home in some ways. Granted, I had a pretty short commute, but it's interesting how it cuts both ways. But what's the experience for a doctor doing specialty telehealth versus in at the hospital or other organization?
It's both. You have to think about peer circles as well as what was the past and what's the sort of the new way of looking at this. So you would look at telemedicine 10 years ago, and more people getting into telemedicine at the time were folks that had spent a lot of years in the hospital, had seen it all, had deep experience, and knew, hey, I can start doing some of this at home through this telemedicine thing. Yeah. Where the modem speeds were high enough, et cetera, that they could actually get good broadband before where we are today. So that was sort of the early adopter pool. In the last literally 3 to 4 years, it's changed dramatically, though. So when you look at the specialists or the physicians that are doing telemedicine, the age demographic, the gender, everything is just basically, it's opportunity to be providing care where you want to be providing it. right? So if you have that element of, look, I need to be taking care of my family in another location. I got to go back to Cleveland to go take care of my parents. I could be working 1 week at my hospital in my backyard, and the next week I could be there as long as I'm in a quiet room. I have a secure platform. We make sure all of our physicians are on secure platforms because there's all this data and integrity that you need to make sure you're having.
Of course.
You don't have to be there every single day, every single week to be providing that care. And I think the element on making the tools and the technologies very user-friendly, it's too common of a buzzword, but medicine is hard enough to make the interaction that you're having with a patient be even more complex. You're already having to think through labs and pharmaceuticals and images to make sure you're getting things done correctly. But as you start to unwind, you realize our specialists and specialists that are doing telemedicine, you're still a member of that medical staff of whatever hospital you're queuing into to provide care. You still get to know, you may not be seeing a patient at that one hospital every single hour, but you get to know the staff. You start to create a relationship with that staff, even though they're not the ones you see feet on the street every day. It's a team, and that team still starts to create bonds that allow for better and better patient care as well. And so I think Zoom has helped people understand what that actually looks like and feels like. We have hired many, many people in the last year, and none of us have met live, but we feel pretty connected because when we're not talking work, you get some time to catch up on family, you get some other times to connect. And I think telemedicine is no different. So as you think through the experience, our physicians are on 3 screens, where the middle screen is like this. My left screen might be the labs and the images that I need to see for proper diagnosis. And my right basically looks like their electronic medical record, where I see the past notes. I've been putting in my current notes, and we're having a transaction, but we don't lose eye contact. And in fact, it's in many ways, if you've ever worked in a hospital, you're constantly someone's nudging you in the shoulder to check in on this or check in on that. And the fact that you can actually be undistracted from those elements because you're in a room and you can get quiet is enjoyable. And we have a lot of interest for physicians to come and nurses and others to come work with us, because they want some of that time on the floor, but they also need time to be flexible for their own lifestyle, for their own families, for just the difference of not being in the same place. People do it for very different reasons, but every one of those comes with a pretty personal story on the why, and I don't think that's ever going to change.
Yeah, it sounds like you need an incentive program after, the 500th visit with that hospital and that nurse. You get to fly out and have dinner with them. It's interesting because, you get that inhuman eventually. But, it's interesting your comments about, who does it. Are the majority of them doing it hybrid, where they still have some physical presence in some organization, and then they're doing the specialty work with you on the side, or for, like you said, 1 week in person, 1 week doing it virtual? Is that how most of them are, or are there some that are full telehealth?
It's a little bit more B. I mean, we have a number of individuals on our teams that are full-time, all telehealth, period, in the sentence, right?
Okay.
They have a lot of experience in the hospitals. They know what that looks like. They're not losing that experience. They know how to think through these technical and complex cases, and they can do that fully remote, right? As long as you're in a secure element, they're doing 100% of all of their cases purely telemedicine. And then other elements, right? You might think about, I might be someone who likes the academic side of medicine. Mm-hmm. So I still want to be able to go into the academic hospital and be providing hours there, and then also be just getting my time to see patients on hand, because academic elements might be longer cases. You're teaching others next to you, right? And this is where I just get time to make sure my own skills are sharp as I'm sitting down and talking with patients and doing diagnosis and exams. And so it is another bifurcation of what we see on people wanting to do this full time, or people first putting their toe into it.
Yeah.
Then we see also, of course, as any company, we're looking for individuals who are really positive, really collaborative. And it doesn't matter if you're talking in healthcare, outside of healthcare, right? You just have a general spectrum of that. And the fact that we get to find individuals that we want to work with, and that our hospitals and our customers want to work with them, it's a pretty special opportunity where you're not confined to geography, to
Mhm.
find all those individuals.
Do you think there will ever be a day that a doctor will graduate and go straight to a telehealth like this? Or with the specialty specific, do you kind of need those hours in the hospital to know kind of the workings before you could really dive into this?
It's a great question. I think obviously the schools do a great job on giving people a lot of experience. I mean, if you're a specialist, it's not like you're getting out of medical school by the time you're
Yeah,
24,
you still have
right?
the residencies, et
You
cetera.
still have
So
all your
you're almost
residencies.
forced to do it,
Yeah,
right?
you're already putting in another 10 years past everybody else getting out of your normal 4 years of college anyway.
Right.
So they're having a lot of time working in a lot of different hospitals under a lot of different scenarios. And so could they? I actually think the answer is yes. I think the element, though, so many people get into medicine because they're naturally curious and they're creatures of wanting to be pushed and using the intellect that, their God-given intellect to really sort of dive into the details. So I think just the human side of that, maybe still people would start in the hospitals, but everything's changing. So
Yeah.
I think the day will change where, there's going to be as many people coming right out of medical school saying, I'm full-time tele. I see no doubt about that.
Yeah. John, as usual, this was awesome. Loved learning more about kind of these dynamics. I think a lot of people haven't dove into really what goes into it. So thanks so much for sharing. Appreciate you having you here. And thanks everyone for watching. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com. Thanks, John.
You're welcome.